Yesterday was kind of a cool day. Start things off with a fistulogram, a two-site plasty, axillary or the cephalic arch, and then another little short segment web-like stenosis in the mid left arm venous outflow. After that, yeah, did a little embolization actually. So nice Asian lady with her daughter. She speaks Mandarin. Daughter speaks English, but the patient speaks Mandarin. So basically showed up to this hospital with a very large fungating, ulcerated, bleeding gastric mass measuring up to 7 centimeters on axial imaging. Chronically bleeding, requiring blood transfusions. Endoscopist says they can't really help this lady. So we took her down, did a little right groin access, came up celiac, basically did some angiography, actually got into her right gastric artery, and did a little embo of her right gastric artery, and then also did a coil embolization of the GDA. On some of these angiographies, I saw a very vigorous tumoral blush, so I do think we did the right thing here. I think we're decreasing vascularity to this large gastric mass, and curious to see if that's going to result in a good clinical outcome in terms of less bleeding. So that was pretty nice. Closed that groin with a perclose. Like that device, it just gives a nice, tight, reliable closure, and case went very smooth. Working alongside Jay, which is a pleasure, of course. After that, did a little bilateral nephrostomy. The patient that came in basically is diagnosed with a huge bladder mass obstructing both ureters. I'd say he had moderate hydronephrosis. I like using 18 gauge Chivas on this. I like to use ultrasound guidance and just get nice one stick. Just find a decent sized calyx, just pop right in. We did spend some time on both sides trying to see if we could cross from the ureter into the bladder. What we saw were basically flush occlusions of both ureters. This is a pretty well-grown mass that basically has occluded these ureters. We poked around for a little bit trying to cross into the bladder. It didn't really work out. So I ended up just placing the nephrostomies. Interestingly, the patient's family member, the daughter, she was very insistent that everything be done today. She was like, we would like, him to have stents placed. We would like a biopsy done. We want to know what this is. We don't want to get a lot of procedures. The patient's about 90, by the way. I was trying to tell her that, theoretically we could try to accomplish all those things in one go, but that's not really how I like to practice. I like to make a decent-sized gain right up front, and to me that means diverting the kidneys with the nephrostomies and kind of getting out, letting that kind of settle down. But it's interesting how these patients, you see just a different perspective. Her perspective is, I want one procedure to get everything done. Theoretically we could have done, if it was technically successful, we could have done, access, get down past the mass, do a brush biopsy of the mass, place double J stents, and then leave covering nephrostomies, or even just take the nephrostomies out and just leave double J stents. We could have theoretically done that. I don't know that I would like to practice that way, but I mean, it's interesting to see how some patients are wanting it done that way. They're thinking, I want one procedure to just sort of take care of the patient and stay out of the hospital. The way I'm seeing it is once you start going down this line, you sort of started a contract with us where you're going to probably need multiple procedures over the next few weeks to months. But everybody experiences healthcare a little bit differently. That's the interesting thing about it as a physician. You just get to see different perspectives. I did attempt to get down, but it just didn't work out, and so I was kind of forced in my position. But I think this is what it is. Talking to patients, talking to their families, keeps you on your toes. It keeps you rethinking and reanalyzing and deciding, are you doing the right thing? Keeps you guessing a little bit, and it makes it interesting, and that's why I love this game. So I'm gonna get up in here. I'm gonna follow up on some of those patients today. I think I got some kind of routine type cases, just some abscess drains, maybe a biopsy, but you never know. 400 bed hospital, something could go down, and if it does go down, definitely I'm ready. Yeah, just trying to enjoy life out here, Strong Arm D.